In this video, we describe how to dissect the retroperitoneal structures of the abdomen. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. I once heard an experienced surgeon give some advice to an aspiring surgery resident. He told her, if you want to succeed in this profession, eat when you can, sleep when you can, and stay the hell away from the pancreas. The first two are obvious. This is in the days when a surgery resident often spent well over 100 hours at the hospital. But what is difficult about the pancreas? Turns out that anatomical variations in this region of the retroperitoneal space are common, and the pancreas can be easily torn, leading to catastrophic outcomes for the patient. In this video, we will explore the remaining portion of the abdomen, the retroperitoneal space, and its organs. Let's dissect the retroperitoneal space and its organs. Previously, we dissected the blood supply of the gastrointestinal tract from the lower esophagus to the sigmoid colon. The small and large intestines are relatively loose from their attachments to the posterior abdominal wall, and this is shown in the image. The first goal of the dissection is to tie off the sigmoid colon as low as possible and cut it to leave a free end. Ultimately, in this dissection, we will remove the intact GI tract to gain access to the retroperitoneal organs. At this point, we go lateral to the descending colon and cut the peritoneum that is holding the colon to the posterior abdominal wall. What is interesting about this approach is that this area of the peritoneum represents the avascular plane of the vessels supplying the large intestines. It is called the white line of Tolt. Consequently, it can be used surgically for incisions to minimize blood loss when the colon needs to be resected. After freeing the descending colon, the intestines are retracted to the right side, exposing the retroperitoneal area. Realize that additional ligaments and membranes need to be cut to render the image now presented in the video. For example, the 3 unpaired visceral arteries to the intestines need to be cut at the level of the aorta. The esophagus needs to be cut, as well as the ligaments of the liver that anchor it to the body wall. In general, removal of the abdominal content is a detailed protocol practiced in some schools to facilitate the dissection of the retroperitoneal space. It was done in this dissection to enhance the visual field. However, everything that is shown on the left side of the cadaver is possible to see without completely removing the entirety of the abdominal content. Nevertheless, the reflection of the intestines now allows us to observe the extent of the peritoneum covering the posterior abdominal wall. Using scissor technique, the peritoneum needs to be removed. Ultimately, the intent is to completely remove the intestines and intraperitoneal organs and place them on a tray in order to inspect them from behind. Finally, after working for some time, the aorta is exposed, but we also took care in removing the peritoneum so that numerous other structures are also visible. First, we note the inferior vena cava, commonly abbreviated IVC in most textbooks. Next, we can identify the 3 unpaired visceral arteries, the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, exceptionally small in this specimen. The next vessels that are visible are the paired gonadal arteries. These are ovarian in a female and testicular in the male. Expect variations in the blood supply. The gonadal vessels can arise from a common trunk or from disparate regions of the aorta, as in this specimen. Present in the retroperitoneal space are the 2 kidneys, enveloped in perirenal fat. This fat helps protect the kidney. The left renal vein is clearly visible exiting the left kidney and draining to the IVC. Now note the differences in the pattern of the right gonadal vein versus the left gonadal vein and how they drain. The right drains to the IVC, whereas the left drains to the left renal vein. Let's now focus on this region of the left renal vein because of the implications for how this disparate draining pattern in the veins is associated with clinical symptoms. Let's again examine the general arterial blood supply associated with the area of the left kidney. And now zoom in specifically to the region of the left renal vein. Let's now label the relevant actors. We see the IVC, the left renal vein, the celiac trunk, and the superior mesenteric artery, the SMA. And what does the left renal vein sandwiched between the SMA and the aorta remind you of? If you say a nutcracker, you would be correct. This is not a trivial observation. It is now believed that this relationship is the reason that the left renal vein can be impinged upon by the SMA and lead to the nutcracker effect. Continuing with the blood supply arising from the aorta, we can now discern additional paired vessels. We see the left inferior phrenic artery going to the underside of the diaphragm and the left middle suprarenal artery. The middle suprarenal artery is accompanied by the corresponding vein, which also drains the left renal vein. Remember, in the previous video, we discussed the vessels that would supply the intestines. In this video, we are presenting the vessels that supply the rest of the abdomen. The goal now is to clean up the area as best we can using scissors technique so that the arterial blood supply of this area can be observed. And after what can seem to the students as a painstaking enterprise, we can identify the following after cleaning up the connective tissue in this area: the aorta, IVC, the left renal vein, the celiac trunk, and the SMA, the suprarenal gland and the kidney, the left gonadal artery, the left gonadal vein. We now see a new structure, the ureter. We can also again observe the left inferior phrenic artery and the left middle suprarenal artery and suprarenal vein. So you can imagine why this dissection takes quite a bit of time to produce and does not always appear as in this image. But if you have been following along, we have described the renal veins, but what about the arteries? The renal arteries lie posterior to the veins, and these must be cut and retracted to expose the arteries, as is now being indicated in the video. Having retracted the IVC and renal veins, we can now label the right and left renal arteries posterior to the veins. At this point, it becomes necessary to examine the internal structures of the kidneys. To do this, we need to use a scalpel and slice the kidneys in the sagittal plane as is being indicated in the image. In this dissection, the right kidney was left in situ after slicing the sagittal plane to demonstrate the relevant anatomy. For reference points, we again leave the IVC and aorta intact and the gonadal artery and vein. Note the course of the ureter. The gross anatomy study of the kidney is generally performed after extirpating the kidney and its associated structures out of the cadaver, as is now being shown in the image. The kidney is generally surrounded by vast amounts of fat, and this is to protect the mobile kidney. This fat is called perirenal fat and is generally contained within the perirenal capsule. Generally, all this fat is removed, exposing the renal capsule of the kidney proper. Note that we're looking at the kidney from behind. How can you tell? In the image, the artery is in front of the vein. Remember, when we were performing the dissection, we had to remove the vein to expose the artery. Once the kidney is free of fat, we use the scalpel to slice it down its sagittal plane. And we can now see inside the kidney. The kidney is completely encased in a capsule, the renal capsule. The parenchyma of the kidney consists of a narrow renal cortex, granular in appearance, and a wider renal medulla, consisting of various columns and pyramids. The segmental arterial system of the kidney is found within the columns, and the collecting ducts and renal corpuscles are present in the pyramids. The arrangement of the segmental blood supply is beneficial to the kidney. You can infarct one artery and will only impart that particular region of the kidney, not the complete kidney. On the left hand of the image, we can now see that the base of the pyramids are facing outwardly, and they come to a point, the renal papilla. Fluid will collect at the papilla, then enter a minor calyx that will combine with other minor calyces to form a major calyx to give rise to the renal pelvis. From the pelvis, urine will then enter the ureter. In essence, these are the structures of the urinary system. Before leaving the arteries that exit the aorta, I would be remiss if I did not bring up the last set of arteries that have not been discussed, the lumbar arteries. These are periparietal arteries. To observe these arteries that exit the dorsum of the aorta, we must first reflect the aorta to the left or right side using considerable force. Then, look at the small arteries leaving the aorta from its back side. These are the lumbar arteries. One last note with respect to the renal circulation. Expect variations, many of them. It is one of the reasons why I favor dissection as a way of learning anatomy. In a large classroom where several cadavers are being dissected, it is likely that you will observe variations in this area, as is being shown in the specimen. Can you see it? Let's label some obvious structures that you are now familiar with and should be able to readily identify. Here they are. For example, note the left suprarenal gland, left kidney, descending colon, and some of the major vessels, the aorta, IVC, IMA, right common iliac artery. But what is the variation? Look where the left renal vein is draining to, posterior to the aorta, at the level of the left iliac vein. Is this common? It is not uncommon. And look at the left gonadal vein and left suprarenal vein. They drain to the left renal vein as expected. If you wish to understand how these variations occur, it is necessary to go back to embryology and review the development of the kidney. I will not go into it here, however. Given that we had taken the entire GI tract out of the cadaver, we can look at it from behind, as is being shown in this image. And if we zoom in on the liver, we can appreciate its different lobes. The right lobe and left lobe of the liver we saw from the front. But now we can distinguish the quadrate lobe, because it looks somewhat square, from the caudate lobe, which is at the back of the liver. We can also see that the IVC is outside the liver, whereas a portal vein drains into the liver. And one last structure, the ligamentous venosum, located between the caudate lobe and the left lobes of the liver. It represents a fibrous remnant of the ductus venosus of the fetal circulation. Let's look again at the viscera from behind and focus on the remaining organs. Here they are. We again see the liver, the gallbladder, the duodenum, jejunum, and spleen. Let's focus now on the duodenum and realize that the duodenum is subdivided into 4 distinct parts, labeled parts 1 to 4. The first part we saw previously and begins intraperitoneal. It is contiguous with the stomach. Parts 2 and 3 of the duodenum are completely retroperitoneal, and interestingly, it is part 2 that receives the bile duct. Note how the second and third part of the duodenum cradle the head of the pancreas, and it is the head that we find the main pancreatic duct joining the bile duct. This view may give you an idea of why pancreatic cancer of the head of the pancreas is often associated with jaundice, whereas jaundice may not ensue until later in the progression of the cancer if it starts in the body and tail of the pancreas. Pancreatic cancer of the head may quickly block the drainage of the bile from the bile duct, and this is what leads to the jaundice. The last step in this dissection is to slice open the second part of the duodenum away from the opening of the bile duct and to look inside the duodenum. You can now see inside of the second part of the duodenum where the bile duct and the main pancreatic duct empty, and this is known as the major duodenal papilla. It is precisely at this location that a gastroenterologist will lead their scope to perform an ERCP, short for endoscopic retrograde cholangiopancreaticography. A radiographic dense dye will be introduced into the biliary tree to discern if there are blockages and the cause of the jaundice. We're now at the last section of this dissection, the demonstration of the muscles that make up the posterior abdominal wall itself. We start by removing the two kidneys, if still present. And we are left with basically a layer of peritoneum covering the muscle layers and the nerves that form the lumbar plexus. We need to remove all of this peritoneum using scissor technique, but leaving the nerves behind. It is best to do this on one side first, then the other. We can see that the peritoneum was removed from the right posterior abdominal wall, and for reference points, we left the aorta, IVC, and the descending colon. What muscles make up the posterior abdominal wall? Starting superiorly, we first note the diaphragm. This might seem surprising at first, but remember, the diaphragm is dome-shaped. Hence, its origin, as we will see shortly, are located within the posterior abdominal wall of muscles. Next, we know the transversus abdominis. Yes, the same muscle that helped form the anterior abdominal wall. We're here looking at its origin in the posterior wall. Moving somewhat medially, the quadratus lumborum is labeled. What is so special about this muscle? It is an accessory muscle of respiration. But as you age, and perhaps you start to slouch, and your posture goes to hell, you may start developing lower back pain. Thank this muscle for this muscular pain. Within the ilium, we have a muscle, the iliacus, that together with the psoas major, now labeled, are what trainers are referring to when they mention your core muscles. The quadratus is also part of your core, as are the intermediate muscles of the back, which we will study later in a different section. Remember, we also studied other core muscles when we studied the abdominal wall muscles during the first video in this abdomen series. The iliacus and psoas major fuse as they exit the pelvis to become the iliopsoas, and they represent strong flexors of the hip joint. Indeed, in days of yore, when people would do sit-ups with their knees straight, these were the muscles that were being used while at the same time straining the quadratus lumborum. Marines were expected to do 100 of these sit-ups in less than 2 minutes to obtain a perfect score. Today, it is acknowledged that Marines laid their foundation for scores of young men and women to suffer lower back pain as they age. Instead, do planks. One final note on the psoas major. In quadrupeds, the muscle is rarely used and is quite tender. Indeed, the psoas major is known as a filet mignon at a fancy restaurant. Having demonstrated the muscles, let's look at the nerves now that make up the lumbar plexus. We start with the subcostal, or T12. As you would expect, the nerve runs just underneath the 12th rib, it is both motor and sensory. Below the subcostal is the ilioinguinal iliohypogastric. The reason for these two names is that the nerve can split into these two nerves. Usually, however, the nerve is still combined at this point. Piercing the front of the psoas muscle, the only nerve to actually do this, is the genitofemoral nerve. This is the nerve responsible for the cremasteric reflex in males. Arising lateral to the psoas is the lateral femoral cutaneous nerve. It is strictly sensory. If you've ever heard of a hip pointer injury in football, this is the nerve that is being injured. Also lateral to the psoas muscle is the femoral nerve, a large nerve that is both motor and sensory to the muscles of the thigh. Finally, if you dig medially and deep to the psoas muscle, you will find the last nerve in this plexus, the obturator nerve, also motor and sensory to the muscles of the inner thigh. And because not all posterior abdominal walls look the same, I thought I would demonstrate a second set of muscles in this video with their labels. Also, once again label the nerves of the lumbar plexus. The subcostal nerve, the ilioinguinal iliohypogastric nerve, the genitofemoral nerve, the lateral femoral cutaneous nerve, the femoral nerve, and the obturator nerve. Moving now to the origins of the diaphragm to demonstrate why it forms part of the posterior abdominal wall, we look at an image of the diaphragm from below. In the midline, we can make out the esophageal hiatus, the aortic hiatus, and the lighter area is the central tendon of the diaphragm. Note, in this image, the opening of the IVC is not readily apparent. Going back to the posterior abdominal wall image, we focus on the portion of the muscles that arise from the vertebrae themselves, and these are the roots of the diaphragm. We now zoom in on these roots and again identify the quadratus lumborum and the psoas major. Turns out that each of these muscles are associated with a ligament that gives rise to an attachment of the diaphragm. The lateral arcuate ligament, as its name implies, is lateral to the medial arcuate ligament. The former domes over the proximal attachment of the quadratus lumborum and is an attachment for the diaphragm. The medial arcuate ligament domes over the psoas major, and it too is an origin of the diaphragm. Moving more medially, we find a muscle, the right crus. The right crus is one of the origins of the diaphragm proper. And if you follow the right crus, it is joined to the left crus by the median arcuate ligament over the aortic hiatus. Don't think for a moment, however, that the aorta pierces the diaphragm. It does not. The aorta runs posterior to the origins of the diaphragm. Think of the alternatives. If the aorta ran through the diaphragm, think what would happen to the blood flow to the abdomen and the rest of the body each time we breathe. It would be cut off. Fortunately, evolution got this one right. We're now fully zoomed in the area of the crura of the diaphragm, but in addition, we can see the esophagus and the aorta still in the thoracic cavity. The esophagus was pulled away from its esophageal hiatus. The dome of the diaphragm is labeled for orientation purposes. Now we can see the opening of the IVC in the central tendon, as well as the opening of the esophagus. The median arcuate ligament, arching over the aorta, can be discerned. The right crus is now labeled and can be observed to form a sling that surrounds the opening of the esophagus. When we suffer from esophageal reflux, it is this muscle that is no longer functioning as a sphincter, permitting the stomach content to reflux into the esophagus. But where is the left crus? It is just to the left of the right crus, and it does contribute to the median arcuate ligament. However, it is not a strong contributor to esophageal opening, as the right crus. Finally, remember in the previous video when we mentioned that all the abdominal arteries were covered with nervous tissue representing the autonomic system? What were these nerves? I hope you have not forgotten the sympathetic trunk that we dissected in the thorax and the preganglionic fibers that emerged from this trunk, the largest being the greater splenic nerve, now labeled in the image. Where does this nerve go? I again show you an image of the right crus, the median arcuate ligament, the aorta, and the associated structures. The greater splenic nerve enters the abdomen deep to the crura of the diaphragm, and there will travel to form the plexus surrounding the celiac trunk, SMA and IMA. Note in this image, the actual plexuses were removed in order to demonstrate the arteries. This now concludes this video on the retroperitoneal space and the organs.